Three, two, one. We are live now, sir.
Good evening, all of you. Myself, Dr. Vishal Dave, Medical Advisor at Intas Pharmaceuticals. On behalf of Intas Pharmaceuticals, I welcome you all for this Fox's Symbiosis Series Webinar 18, Best of Symbiosis Episode 2 by Bhopal Obstetrics and Gynecology Society. Before starting the webinar, we would like to have a live lighting ceremony.
शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः.
Now I'd like to introduce Dr. Monica Singh. Dr. Monica Singh is consultant reproductive medicine, Bhopal Fertility and Endoscopy Center. She is professor at LN Medical College, Bhopal. She is managing committee member, ESAR. She is West Zone Coordinator, Medical Disorders Committee, FOXY. She is convener of ESAR Perfection Series and convener of FOXY Symbiosis Series. Over to Dr. Monica Singh, madam.
Thank you so much, Dr. Vishal Dave. Medical in charge from Intas Pharmaceutical, our pharma partners for this academic series. And at the outset, I would like to extend hearty welcome to our guests of honor, Dr. Revati Janakiram ma'am and Dr. Kiran Kotkoti sir, who have joined. Good evening, sir. Good evening, ma'am. And I would also like to extend a warm welcome to our VP South Zone, Dr. Charmila Ayabu, who's always prompt in joining and has joined exact on time before that only. So this Symbiosis series we started in September 2023. We finished 16 fantastic episodes with all the Foxy committees. After that, we thought that let us end it with Best of Symbiosis. So Best of Symbiosis doesn't involve Foxy committees, but it has some of the best lectures from speakers all over India. So this time we have got Dr. Charmila Ayubu herself, who will be deliberating on principles of normal cesarean section and tackling difficult situations. We have Dr. Girija Wagh, Vice President Foxy, who will be deliberating on PPH. And the third speaker is Dr. Parag Biniwale, who is unable to join today because of ill health. In his place, I will be joining in as speaker, third speaker, and I'll be speaking on antenatal interventions to improve perinatal outcome. The WHO guidelines. So without wasting time, let me first thank the office bearers of Foxy, our respected President Sir, Dr. Jaideep Tang, and our respected Secretary General, Madam Dr. Madhuri Patel, without whose blessings we could not have carried this series forward so beautifully. Dr. Jaideep Tang's blessings are always with this program, and he joins us wherever he can. Yesterday, he was there with us in a breastfeeding webinar, and he always is there to, share his views. And Dr. Madhuri Patel ma'am is also one person who always takes out time, but right now she is with family and commitments, so she might not be able to join today. And now I would like to I would like to welcome warmly our Dr. Suchitra ma'am is there, Purva? Not yet?
Ma'am is joining in 10 minutes.
Okay, so we will, Dr. Vishal, we will introduce our guests of honor first. I take great pleasure in welcoming and introducing Dr. Revati Janakiram in front of all of us, the August gathering. Madam is past Vice President Foxy, and she is a very, very senior gynecologist. She has been Vice President Foxy South Zone in 2016, former Director IOG Chennai, and President of TN Fog in 2023. Madam is the Founder Secretary and past President of Madurai OBG Society, Founder President of Madurai Menopause Society, Zonal Coordinator of Foxy ACS HPV Vaccination Drive, recipient of Foxy Duru Shah Community Services Award, recipient of Lifetime Achievement Award by IMA Madurai, selected as Master Trainer for PPIUCD program by FIGO Foxy, author of Amniotic Fluid A to Z chapter on Foxy Focus, contributed many chapters in Foxy Focus and contributed many chapters in UG books, PG books, and the recipient of Pride of Foxy Award in November 2019 at Mumbai. We are so honored and blessed to have you, madam, amongst us, and kindly provide us a little speech for encouraging us, madam.
Thank you. Thank you, Dr. Monica, for your kind words.
I really appreciate and congratulate your team for organizing such wonderful webinars. The second episode of Best of Symbiosis. And the topics and the speakers chosen are really excellent. So practical things. Okay, even though we make a big hue and cry about this increasing rate of cesarean section, every practitioner should know how to do it properly and how to do it without any harm to the mother or the baby and to tackle the difficult situations. And we have got excellent speaker, Dr. Chamila, to talk on that. And PAH and PPH are the favorite topics of Dr. Girija work. And I'm sure she will be delivering a good talk on that topic also. And the third topic, as you said, Dr. Parag is supposed to do, but you will be doing that. And on seeing that, I just remembered just day before yesterday, one of my patients, she was a staff nurse in Government Rajaji Hospital, and she came with her son, who was 30 years old, just to get blessing from me. And, I was surprised that I conducted a vaginal delivery, assisted breech vaginal delivery. I can deliver that boy and 3.75 kg boy vaginally in my private clinic long back. Okay. So we were doing even this mid cavity forceps, 80 forceps, right and left, we were using it. And I'm afraid present generation, they are even afraid of touching that 80 forceps. So when we say that we have to bring down the cesarean section rate, we have to encourage and train our juniors, the younger generation, about this assisted vaginal deliveries also. So we have to train them and then encourage them, and we have to necessarily revive this art of vaginal delivery. And I'm very happy that you have chosen such wonderful topics, and I congratulate you again for your organizing such a wonderful thing, and wish you success in every future endeavor. Thank you very much.
Thank you, Revati ma'am. That was very, very encouraging, and your blessings mean a lot to all of us juniors. And because obstetrics is now a dying art, we are now relying increasingly on C-sections. And it is for stalwarts like you to teach the younger generation. We are the middle generation. The younger generation needs to know how to bring down the C-section rate. And who better to guide us than our President AMOX, Dr. Kiran Kutkoti sir from Pune, who has joined us as the guest of honor. Sir's blessings are always with us, and he is a very, very dynamic figure in Foxy with experience at national, state, at local level. Sir has been, he's at present the president of AMOX, which is a congregation of nearly more than 48 or 40, I think 48 to 50 societies. I think Maharashtra has the maximum number of Foxy societies. And he's also the ex-chairperson MTP Committee Foxy, ex-chairperson MTP Committee AMOX, ex-chairperson Medical Education Research and Training
Okay,
AMOX.
Dr. Monica, fine.
Thank
Fine.
Sir, I will not take much of your
Yeah,
time. We really want to listen to you today, sir.
At the outset, my warmest greeting to Foxy office bearers, Dr. Jaideep and Madhuri. Today's chief guest, Dr. Suchitra, my co-guest of honor, Dr. Revati ji, madam. Namaskar and pranam to all of you. And very, very big congratulations to the power couple of Isar or Foxy, you can say, Randhir and Monica. You have been for doing fantastic series, and the name of the series also Symbiosis, very apt name that you have kept. And really, it's a fortune for I'm fortunate that I'm one of the guests of honor, so that I'll be listening to all the talks by none other than Dr. Charmila. I have met Charmila in innumerable webinars and a very excellent speaker. And of course, Dr. Girisha, my own colleague from Pune. And even though Parag is not there, I think Dr. Monica, I think you'll do justice to the topic. So over and all, I wish you a very best of luck. And I thank you basically for conducting this particular webinar series. Actually speaking, what we should be doing is record all the series and create a huge record bank. I mean, that is what we should we can expect from Intas probably. I think Vishalji is listening to that. Okay, so
Yes,
if at all, yeah, because see, it is such a huge clinical pool, a research pool that we have had over the past 3 to 4 years, and it has to be banked somewhere. It has to be stored somewhere, whether on cloud or because after all, it's a property of maybe a joint property of Intas and Foxy. Okay, but it has to be stored somewhere, so that all the postgraduates can have access to that in the future. Even we can have access to that in the future. So I think you should look into that, and I would definitely Hope, wish, and pray that you look into that direction. My best wishes, Dr. Monica, and please get on with the program. Thank you so much. Thank you so much. Look forward to lots such webinars and look forward to seeing you frequently on Foxy platforms.
Thank you.
Thank
Thank you
you
so
so
much.
much.
Thank you
Namaste.
so much for your blessings, sir. And
Namaste.
my colleague is also there with me, Dr. Dipti Gupta, who is
Yes, yes. My best wishes to Dipti
yes,
ji.
yes.
Heard
So
a
sir,
Thank you, sir.
lot of praises of Dr. Dipti because she's been working very closely with the quiz committee with Dr. Nilesh Balkavade, who is the joint secretary of AMOGS and of course my good friend. So Dr. Dipti ji, a very best wishes to you, and I'm sure you will show your merit and talent in the near future. Thank you so
Thank
much.
you so much, sir. Thank you, Monica ma'am.
thank you so much. And sir, for the record, we have got very good news that it was when we started Perfection series and Symbiosis series. Perfection is with Isar and Symbiosis is with Foxy. We took permission and we have got all these episodes nicely recorded on YouTube, and it is accessible to everyone free of cost, sir. There is no charge. Everybody can take the link, and Intaz has got all the episodes also, sir. And
Fantastic.
we'll be very happy to provide it for any sort of academic this thing, sir.
Really.
Requirement.
Excellent, excellent.
Excellent.
Thank
Thank you.
you. Thank you.
That's a very encouraging, nice news. Thank you.
Thank you. Thank you, sir. Thank you, Revati ma'am. Thank you, Kiran Kotkoti, sir. Your presence means the world to us. And now I would like to, because Suchitra ma'am is, I think we will introduce her whenever madam joins. I think we can now start by thanking our Bhopal OBGY Society office bearers. Can you do the honors, Dr. Purva? Or Dr. Neetu is there? Dr. Neetu can do the honors.
Yes, ma'am.
Madam, Dr. Anita Srivastav is not well. She is running a fever, and Dr. Shabana and I, we were in the rally for the Kolkata
Yes.
case. So, doctor, so you can just take their names and we can move on.
We have two dynamic faculties as our chairperson in Bhopal OBGYN Society, Dr. Anita Srivastav, madam. She is currently assistant professor at Chirayu Medical College and president of our Bhopal
Neetu, we can
OBGYN
skip
Society.
we can skip
And
the
our
introduction.
secretary is as dynamic as our
Neetu, we can skip the introduction.
President, Dr. Shabana Sultan ma'am. She is currently head of the department, Gandhi Medical College. Now we will move ahead for the
I'll just
convener and
word
co-convener.
about,
Yes, ma'am.
I'll just speak a word about the coordinators. My co-convener is Dr. Randhir, and I'm always thankful for his contribution to our activities. And I would like to introduce now my three brilliant coordinators. All the messaging, all the program coordination, getting it all together, the setup, everything is done by these three dynamic OBGY specialists from our premier medical colleges. Dr. Neetu Mishra is Associate Professor, Department of OBGY, AIMS Bhopal, a very keen academician, has presented so many studies and is now venturing into ART. And Purva Bhatkur is Assistant Professor in OBGY and Department of OBGY in GMC Bhopal, my alma mater, and she has also presented many papers. She just now took a Yuva oration in MPOX. And Dr. Nandini Singh Bhati, she is not present today, it's her daughter's birthday. She is also an Associate Professor, Department of OBGY at GMC Bhopal. So I really thank these three girls for taking care of my series so beautifully in the last 2 years. So now the program is all yours, Neetu and Purva, to take the
Yes,
first.
ma'am.
Thank
Thank
you.
you, ma'am.
Thank you so much, ma'am. Now we will move quickly ahead for our scientific session. For the first session, we have speaker Dr. Charmila Ayubu, ma'am. She is currently Vice President of Foxy. She will be talking on principles of normal cesarean section and tackling difficult situations. To chair the session, we have three dynamic chairpersons. Dr. Sunita Wadhwani, madam. She is President of Ratlam OBGYN Society. Dr. Padma Shukla, madam. She is President of DIBA OBGYN Society. And Dr. Vandana Gupta, madam. She is President of Katni OBGYN Society. Dr. Sunita Wadhwani, madam, is President of Ratlam OBGYN Society and Director and Consultant of Ratlam Hospital and Research Center. He is also NABH assessor, MBA in Hospital and Healthcare. She has special area of interest in critical obstetrics, and she is also lead assessor and master trainer in Manyata, which is run by Foxy. We welcome you, ma'am, to chair this session. Our next chairperson is Dr. Padma Shukla, madam. She is associate professor and at unit head at Sham Shah Medical College, Riva, and also president of Riva OBGYN Society. She has many publications and many awards in her bag, including CS Dawn Award, Jagdishwari Mishra Award, Foxy Young Talent Award, and Foxy Achievers Award. She has special society awards and area of interest in vaginal surgery, high risk pregnancy, and preventive oncology. We welcome you, ma'am, to chair this session. Our next chairperson is Dr. Vandana Gupta, madam. She is president of Katni OBGYN Society and director of Om Shanti Maternity Hospital, Katni. She is also the founder vice president of Katni OBGYN Society. She is very active in Katni as vice president of IMA, and she is working in obstetrics and he is working in Katni as obstetrician and gynecologist for more than 2 decades, with special area of interest in HPV vaccination and cervical cancer screening, anemia, and high-risk pregnancy. We welcome you, ma'am, to chair this session. Now I hand over the session to our chairs to introduce our speaker and carry forward the session.
A very good evening to all the seniors and friends present on this platform. It is my privilege to introduce to you the speaker for today, who is none other than Dr. Charmila Ayavu, Vice President-elect Foxy 2024. Ma'am is Vice President-elect Trichy Obsgynae Society. She is Chairperson Clinical Research Committee Foxy 2016 to 2018. Ma'am is ICOG Governing Council member from 2021 to 25, National Coordinator for UNICEF Foxy PCA, Medha Foxy PG program, and ISAR Gurukul program from 20 to 23. She has series of convener of ICOG Journal Club and ICOG certificate course of 2022-23, WHO Southeast Asian Region MDSR Indian member, President Menstrual Hygiene Managing Consortium of 2018 to 20, Secretary Gestosis India Association and Academic Wing of Assisted Reproduction Trichy, MC member of PCOS Society of India. Welcome, ma'am. It is a privilege to listen from you on such an important topic.
Thank you so much, Dr. Sunita, for that very, very kind introduction. I'd like to thank Monica for the opportunity, and a dynamic couple, as we always say, as Dr. Kiran sir said, like very difficult to see such active couple and who work continuously for the society. I'd like to thank the guest of honors, Dr. Kiran sir and Dr. Revati ma'am, for honoring the occasion. And a special thanks to all the chairpersons, Dr. Sunita, Dr. Padma, and Dr. Vandana. And the topic which Monica asked me to talk on today is the principles of normal cesarean section and how do you tackle when there's a difficult situation. We have to remember that cesarean birth is part of the standard of care for childbirth, and there's an increase in incidence worldwide, and that's because of rising maternal age of our mothers, the higher rate of previous cesarean sections which have occurred already, obstetrical complications seem to be more now, the higher socioeconomic status and social class, which seems to increase the chance of cesarean. And of course, the final one, which you don't usually accept, is the fear of litigation. And according to Dr. Jaideep Tang, President Foxy, we have to name it as birth and not delivery. And he says the delivery is done with Swiggy and Zomato, and cesarean birth is not birth of an abnormal child. And hence, we cannot call it as a normal delivery when it happens vaginally, and a cesarean delivery should not be labeled as abnormal, because both are children who are born quite fine. That just the mode of delivery is different. So we have to name it a cesarean birth rather than a cesarean delivery, and should call it always normal. And for the requirements for a safe birth, a clinical facility will require an operating room which is functional, a surgeon, an anesthetist, staff, and medications. And the indications for a planned cesarean. Nowadays, we do not go for external cephalic version for all our breaches, but you can try. If it's contraindicated or failed in a term singleton breach, it's better that you go for a planned cesarean. A twin pregnancy with the first twin being a breach should be an indication for a cesarean. Suppose a mother suffers from HIV, or she's got both HIV and hepatitis C, and primary genital herpes in the third trimester is an indication for a planned cesarean, and of course, grade 3 and 4 placenta previa. Cesarean delivery can be a very straightforward procedure in patients with no previous scar, and you anticipate only a minimal blood loss, and the baby is in a vertex position. But remember that complications can arise at any step if you show an inadequate attention or care. And the procedure becomes much more difficult in a repeat cesarean where adhesions, bleeding, infections, problems associated with delivering the baby may occur. So you have to be very, very careful when you're planning for a cesarean. Do not take it for granted. And when you make a decision for cesarean, communication and information is very, very important. And you need to provide the pregnant person with evidence-based information, and you need to obtain a consent for cesarean section. And remember, a competent pregnant woman is entitled to refuse the offer of treatment, such as cesarean section, even when the treatment could clearly benefit her or her baby's health according to you, but she can refuse the offer of treatment. And timing is, want to do an elective section, it's better that you carry it after 39 weeks of gestation to reduce the risk of respiratory morbidity in a baby. And in the case of a suspected or confirmed acute fetal compromise, when you go for an emergency cesarean, the delivery should be accomplished as soon as possible, and the accepted standard is within half an hour. And anytime you do an urgent cesarean section, you have to document the urgency using a particular classification. Category 1 cesarean section is where there's an immediate threat to the life of the women or the fetus, which can happen in a suspected uterine rupture, a major abruption of the placenta, a cord prolapse, fetal hypoxia, or persistent fetal bradycardia. Category 2 is where there's a maternal or fetal compromise, but it's not immediately life-threatening. Category 3 is there's no compromise with the mother or the fetus, but there's a need for an early birth. Category 4 are the elective ones, where you time the birth to suit the woman or the healthcare provider. So there's a codes are also given colors, and the red code is for a category 1 cesarean, which is very, very urgent, and there's an immediate life-threatening maternal or fetal situations, and you need to deliver in the next half an hour according to many guidelines. But in France, they've kept it as 15 minutes when you found out that there's a life-threatening situation for the mother or the baby. It becomes an orange category with an urgent need for a cesarean. It's category 2, which is related to compromise of the mother or the baby, and it's not immediately life-threatening. You can take a time limit of 1.5 hours, that is 75 minutes can be taken. And category 3 is a green category, which is a non-urgent category, where there's no maternal or fetal compromise. Category 4 is the elective cesarean. Regarding the procedural aspects of cesarean, a preoperative assessment with a hemoglobin check, and always give an antibiotic dose, 1 dose of first-generation cephalosporin ampicillin within 1 hour of surgery. Assess the risk of thromboembolic disease in the mother and offer a graduated stockings, hydration, early mobilization, and low molecular heparin. And you need to cite an indwelling bladder catheter. Preoperative care for a healthy person with an uncomplicated pregnancy. There's no need to offer a grouping and saving of serum, cross-matching of blood. A clotting screen is not essential, and you need not do an ultrasound to localize a placenta. And regarding the anesthetic care you'll offer for a cesarean, you have to offer antacids and H2 receptor analogs. And you have to, that is because you need to offer that to prevent an aspiration during the anesthesia. And always offer antiemetics and regional anesthesia as much as possible. And you can reduce the risk of hypotension, which can happen with spinal anesthesia, by giving an intravenous ephedrine or phenylephrine infusion. A volume preloading with crystalloids or colloids is always needed before a cesarean. And please be ready for a lateral tilt of 15 degrees to prevent a hypotension episode. And when you give general anesthesia for an emergency cesarean, remember you need to oxygenate the mother before the induction, and rapid sequence induction is needed to reduce the risk of aspiration. And in all maternity units, you should have a facility for a drill for a failed intubation, where the nurses should respond very, very fast if there's a failed intubation. And in surgical techniques in cesarean, please do not do these. That is, do not close subcutaneous spaces unless it's more than 2 centimeter fat. Do not use wound drains. Do not use separate knives for skin and deeper tissues. Do not use forceps to deliver the baby's head routinely. Do not suture the visceral or the parietal peritoneum routinely. Do not exteriorize the uterus. Do not manually remove the placenta. Wait for the placenta to separate and then remove it. And what you should do during a cesarean is, you should wear a double glove if the mother is HIV positive. Remember to do a transverse lower abdominal incision like Joel Cohen incision, which is much better as far as the early healing is considered. Use a blunt extension of the uterine incision. Give oxytocin 5 units by slow IV once a baby is delivered. Use controlled contraction for removal of the placenta. Close the uterine incision with 2 suture layers. Check the umbilical artery pH if the cesarean has been performed for a fetal compromise. consider women's preferences of birth like music playing in the theater, facilitate early skin-to-skin contact for the mother and the baby to facilitate their bonding. And there's evidence says that there's no need to routinely create a bladder flap during a cesarean because it can lead to increased postoperative urinary retention, worsen postoperative urinary symptoms, and an increased incision to delivery time. And there are RCTs and meta-analysis which have shown that there's no difference in bladder injury with or without development of the bladder flap. And regarding the indication for creation of bladder flap, it can be done in certain indications. Suppose you're doing a cesarean for a failure of descent, where the bladder may be adherent theoretically higher on the lower uterine segment because the lower uterine segment is thinned out. And you're less likely to incise into the bladder if a bladder flap is initially created in these delayed in cesareans where the labor has been there for a long period of time. And when you do the uterine incision, both NICE guidelines and ERAs recommend that the hysterotomy should be extended bluntly in the cephalad chordate direction. And there are significantly fewer unintended extensions of the hysterotomy incision if you do it bluntly. There are lesser injuries to the uterine vessels, and the women tend to experience blood loss, which is lesser when you do a cephalad chordate type of extension. And this is how you do. You don't extend it transversely. You incise it in with your hands in the cephalad and the chordate direction, which seems to reduce the incidence of extension of those hysterotomy incisions. And remember that in obstetrics, it's always, you should be over-prepared. Because if you don't prepare, you could lose everything. If you prepare for the worst and nothing happens, you remember that you've lost nothing. So it's better that you over-prepare for a cesarean instead of assuming that everything will go on well. And what about those difficult cesarean sections? It will happen when there's a difficult access to the lower uterine segment. Suppose it's a complicated fetal extraction, and suppose there's a laceration or organ damage when you're doing the cesarean, there's an abnormal placentation. Difficult access can happen when there's a fibroid. Suppose a mother is extremely obese, or a previous cesarean is a reason that you're going for a repeat cesarean where there may be a difficult access to the lower uterine segment. Excuse me. Suppose there's a fibroid which is more than 5 centimeters. Remember, but the chance of the mother going for a cesarean even before labor is much more. That's almost like 20% according to a study in 2007. And when you're doing cesarean myomectomies, traditionally it was all discouraged because you always feared that there may be additional complications, especially hemorrhages. But there are advantages of doing a cesarean myomectomy. It will reduce the post-pregnancy symptoms because of the fibroid, like pelvic pain and menorrhagia. It will avoid the need for a future myomectomy or hysterectomy when the oncological risk is excluded. And you may have a vaginal delivery in subsequent pregnancies if you're removing that fibroid. And in a systematic review, which analyzed almost 2,300 women who had myomectomies during cesarean and a cohort of 1,599 who did not have a myomectomy, blood loss was definitely more in the myomectomy group, but the number of transfusions did not change. So did not translate to a more of transfusions just because there's blood loss. So you can remove those inconvenient fibroids. And the convenient fibroids are the ones which are like in suitable locations. That is, suppose they should be away from the fallopian tubes, they should be away from the cervix and the main arteries, and then you can remove these fibroids. The steps is you should have to incise over the myoma, which is then enucleated. You can use cautery to reduce the blood loss. But in intramural myomas, do not use too many incisions, because if you're using more than one uterine incision, there's a higher chance of atonic PPH. And in the lower segment uterine myoma, you need not actually deliver the baby and then go for the myoma. If there's a difficulty in reaching the baby, you can remove the myoma and then deliver the baby. But you should use uterotonics to avoid the blood loss. And the next challenge which you will have for a difficult cesarean is the obese mother. Hospital equipment itself will be a challenge because you need a heavier table to holder. You will need more people to lift the patient. You will need an intravenous line incision, which will be a difficulty because of the smaller vessels. There will be not smaller vessels, that because of the obesity, the insertion will be a problem. You will need more experienced personnel for a mother who's obese. Anesthetic difficulties should be anticipated. You've got a higher chance of delivering a macrosomic baby, and you will need an adequate skin incision exposure, which may be a problem if she's very obese, particularly a abdominal wall obesity. And a skin incision in obese mothers, there's been a thought that probably a subumbilical incision will avoid that pad of fat. But remember, in severe obesity, where the mother is having a BMI more than 45, they say supraumbilical transverse incision is much better because it will give a better access to the lower segment and easier delivery of the baby. Probably it will be associated with a higher rate of blood loss and a longer time to complete the operation compared to a classical fan and steel, but it will give you much better access to the lower segment. And you can use a supra or a sublimical transverse incision if she's not an morbidly obese mother, if she's mild or moderately obese. The next challenge will be a previous abdominal surgery with adhesions. In a repeat cesarean, remember to incise very carefully the fascia and the peritoneum, and that should be done to avoid injury to the bowel or bladder, which can be attached to the structures in a previous cesarean. And remember that the degree of adhesions are different in each person, can vary widely among individuals, and it's very impossible to predict how adherent the organs will be. In the presence of adhesions, remember the procedure will be difficult, and the extraction of the baby is also very difficult, and that's why you'll have a longer time to deliver the baby, and the risk of complications such as excessive blood loss and injury to the bowel or bladder are quite increased. And post-operative adhesions will alter the usual structures, can dislocate the bladder to the mid portion of the uterus and create dense adhesions between the bladder and the uterine wall. And when a bladder with an atypical location is not well recognized when you're opening up the abdomen, it can be inadvertently damaged. And bladder damage is increased with increasing cesareans. And the abdominal adhesions are the one will determine the small bowel obstruction. And the rate of obstruction increases with the number of cesarean, like in a bladder injury. And the next problem will be when you're having a difficulty in extracting the baby, and that will happen in a deeply impacted fetal head when there's a prolonged labor and the mother is taken up in advanced labor. And suppose it's a transverse lie presentation, it will give you difficulty while delivering during a cesarean, and the floating head also will create problems, and all are associated with an increased risk of maternal and fetal complications. So how will you deliver when there's a difficulty in delivery of the baby? You can use a vacuum, you can use forceps, you can use a manual, you can do manual delivery utilizing appropriate fundal pressure, or some centers use tocolytic agents to relax the uterus and then deliver the baby, or you can extend the uterine incision like a T-shaped incision or a J-shaped incision. But what does Cochrane evidence say? They say if you use vacuum morphosis compared to a manual extraction at an elective cesarean, there's no instance of birth trauma in either group. You can do whatever you're comfortable with. There are no differences found in the mean fall in hemoglobin between groups or an uterine incision extension. But there are no trials to tell whether you can use there are no evidence to show that whether you can use tocolytic agents to relax the uterus and then deliver. And there's no sufficient information to tell you that you should routinely use instruments to facilitate infant birth at the time of difficult cesarean. So it needs to be based on your practice and what you're comfortable with. And regarding the uterine incision, always use a transverse incision, the lower uterine incision, but you may need to use a low vertical mid-segment or classical incision in reasons like preterm delivery without a well-developed lower uterine segment. Suppose it's a transverse lie with a back-down presentation or a placenta accreta spectrum, then you may actually plan for a hysterectomy, and then you may need to use a vertical incision in the abdomen as well as in the uterus. So remember to plan out your incision depending on the indication for which you're going for a cesarean. But remember, if you're going to put an incision in the contractile portion of the uterus, there's going to be a problem in her future deliveries. And when you're wanting to deliberately extend the incision to deliver the baby, it may be necessary to extend the lateral corner of the transverse incision, either in a J fashion, or you should go for the midline of the transverse incision in an inverted T fashion. But remember, any extension into the contractile portion of the myometrium will be associated with an increased risk of uterine rupture in the subsequent pregnancies. That is, incisions from the lower segment, when they're going into the contractile portion of the upper segment, they're going to cause problems in future pregnancies. And what about deeply impacted head, like a prolonged second stage? There are three maneuvers you can use. It can be a pull or a reverse breech extraction, a head push, or the Patwardhan's maneuver. But what is a best technique? There are 4 randomized trials, and they said there's no difference in birth trauma between both groups. That is, whether the reverse breech is used or a head push, but the chance of endometritis, extension of the uterine incision, mean blood loss, and neonatal ICU admissions are decreased with a reverse breech compared to a push technique. And the operation duration also was significantly shorter for a reverse breech extraction compared to a push where you're pushing from the vaginal area. And the amount of tissue trauma and the blood loss is much lesser when you go for a reverse breech extraction. Patwardhan's technique is where the shoulders of the baby are delivered first, followed by the rotation of the head and the delivery of the posterior shoulder and arm. That is, you deliver by the shoulders and then you somersault the baby and take the baby's breech, and then the head will deliver by itself. But many are not comfortable, but we are used to the Patwardhan's maneuver, and I can say that is one of the safest procedure for a deeply impacted head. And regarding transverse light, the difficulty will be there with the presentation itself. So a traditional low ischemic transverse uterine incision may be the first choice, and I can convert it to a inverted T incision. But remember that when you have a transverse light, it's better that you rotate the baby into either a cephalic or a breech presentation and then take out the baby. And the internal version should be done in such a way that you do not extend those incisions. And it will be very easy if you change it to breech rather than cephalic, because taking out a breech after internal version is much easier in a transverse like compared to going for the head. And during the manipulation, please remember to avoid extending the hysterectomy incision, because that will cause an increased operative time and a blood loss. There may be a damage to the other organs when you're doing a cesarean, and it can happen to the bladder, the ureters, and the GI tract. Even though they are rare, it can happen, and it's important that you find the lesion and repair it with the appropriate surgical technique always. And bladder injuries are common during repeat cesareans, as I said. So always open the peritoneum using the sharp method rather than the blunt technique of Joel Cohen and Miss Gavladix. When you tear through, you can tear through the bladder also. And it will happen when you are doing it for a repeat cesarean. And damage to the dome of the bladder will be more common in the first cesarean, but whereas the injuries to the body of the bladder, the trigone, are increased in a repeat cesarean. And a creation of a bladder flap in such instances, at least 1 to 2 centimeters above the top edge of the bladder, will minimize the risk of bladder injury. And regarding ureteral injuries, they are more common. Suppose you're going to do a surgical procedure in a case of a massive PPH, you may rush to control the bleeding, and that time you can include the ureters in your hemostatic sutures you're taking, and that can include the base of the bladder and the broad ligament. And these cases, a hematoma will surround the damaged ureter, and it becomes infected and then becomes a fistulous communication between the ureter and the uterine cavity. During these procedures, before you put a blind hemostatic sutures, you can extract the uterus out of the abdominal cavity so that you can see where the bleeding has happened and then suture those areas. That may prevent the injury to the ureters. GI injuries can be very rare in terms of cesarean section complications, but when it happens, it's a colon which is most frequently affected. And the risk of intestinal lesions are higher in case of repeated cesareans, and adhesions are the main cause of these accidents. And bowel injuries generally occur during the opening in the peritoneal cavity when you do not do it bluntly by looking at it, sharply by looking at it, and you go for a blunt dissection, you may injure the bowel which is attached to those adhesions. The next problem will be with an abnormal placentation, and that's why a preoperative identification is very, very important. And cesarean is considered the safe and most appropriate method of delivery for a abnormal placentation like placenta accreta. But always remember to avoid cutting through the placenta, otherwise it will bleed torrentially, and that can lead to severe problems in the mother. And that's why you deliver the baby by a vertical incision, take out the baby, and then tackle the placenta. And when case of incision on the placenta, the umbilical cord must be clamped so that the baby does not suffer. And a high vertical incision can be done. Suppose there's a preterm gestation or a transverse presentation along with a problem with the placenta. And there's something called an elective cesarean on maternal request. You need to minimize occurrence by talking with the mother, explaining to her the problems with the cesarean, but still she's got a right to refuse care. Similarly, you also have got a right to refuse care because you feel that she can have a vaginal delivery. And in this case, when you want to refuse, you should offer her the possibility of a second opinion. And the lessons which I have learned in difficult cesarean sections are these, and that is, I had a third gravida who had previous one cesarean, and this time she had a term pregnancy. It was a small baby, it was a growth restricted baby. So I thought a smaller incision will be much better. So I just put a small incision as the baby was small according to ultrasound, but I had so much of difficulty while extracting the baby, and the baby was distressed at birth. I felt that I should have gone for an incision which was adequate when there was a previous cesarean, because sometimes the scar in the abdominal wall as well as the uterine wall sometimes does not give way while you want to extract the baby. So even if it's a cephalic presentation, You put a smaller incision, you may land up with problems. The next is a major floating head in a cesarean, which happens in major placenta previa. We have done with forceps, we've done with vacuum for all this floating head, but somehow internal podalic version seems to be a very good technique where you change the baby to a breech presentation and then deliver the baby. It seems to be easier. But if it's a floating head and the baby you're unable to change the baby, you will need to actually go for a forceps, which will be much simpler. And the third problem which I've had is an obese mother with a small baby. It's very, very difficult to do a cesarean for a mother who's morbidly obese and the baby is growth restricted, because it's so difficult to suture the uterus after you've taken out the baby, because it will stand like a vertical organ and it's so difficult to place your sutures. The fourth problem which I've had is undiagnosed placenta accreta on table when you're diagnosing a placenta accreta. That's the worst thing can happen to a obstetrician, and that's why you have to be prepared for every eventuality, even for the simplest of the cesarean, which you think is simple. And sometimes the uterus will never contract. Whatever uterotonic you give, whatever cannula you put, whatever balloons you keep, you put your sutures, still there will be a problem, and sometimes you may resort to early hysterectomy to save the mother. I had a triplet gestation, but the mother refused a fetal reduction, and she came for a delivery at around 36 to 37 weeks. And once we delivered the baby, we could not control the bleeding, so we had to do for a early hysterectomy. The next thing is an uncorrected DIC, which you have not identified, and you take up the patient for cesarean, you can lose your patients on table. And that's why whenever you have a mother with a hypertensive disorder, a diabetic problem, it's better that you check for any other morbidity before you take her for a cesarean. And I had a mother who weighed 100 kg and she was referred for a cesarean, and she had gestational hypertension, hydramnios, and she was an uncontrolled GDM on injection insulin. She was taking it quite irregularly. We posted her for an elective cesarean with all adequate precautions. We kept a lumbar wedge pillow to prevent a hypotension, but still, on putting her on the table, she developed hypotension and hypoxia when she was put under spinal. She delivered a male baby of almost weight of 5.8 kg. I delivered her within the next 3 minutes after she developed hypotension. She was simultaneously intubated while I was delivering. And we had put a prophylactic uterine balloon tamponade because the uterus was over-distended because of the big baby there. And along with uterotonics, she was put. But still, I did not extubate her. She was shifted with the ventilator to a tertiary care center because she had so much of morbid problems, and I did not want to lose her because she developed such a severe hypotensive episode. I just put on a supine position. And one patient, she was opened up for an emergency surgery, and they found out milky fluid, and she was referred to our hospital. And we could not identify why this milky fluid was happening, and we could not do anything. We tried all the conservative measures, and then we lost her. It was actually a mesenteric artery thrombosis, and she's landed up with lymph in her abdominal cavity. So when you have unexpected findings on cesarean, please do follow up, evaluate the patient, and don't leave her alone. You may identify a cause which can help her. And we have had patients referred with so-called PPH. And when they kept on giving uterotonics, but we said it's not getting controlled, let's open her up. When we reopened her, we found out an angle which was just pumping blood. So you may think that you're doing the most appropriate suturing, but remember that even the simplest of cesareans, you can land up with problems like this. Then we had a patient who had a divarication of the recti. So the surgeon was assisting me. He said, let's do double breasting and all that. Unnecessary procedures were done along with the cesarean. And the mother landed up with an inferior epigastric hematoma, which he could not identify. Post-delivery, she was oozing from a wound. And then we opened her up, we found out a hematoma. So unnecessary procedures should not be combined with a cesarean section. And these are my references. And sometimes you need an out-of-the-box thinking in obstetrics. We had a 30-year-old primey she had a skin grafting done for burns in a young age. And she had another laparotomy done in her adolescence. There were no details available. And she had such a bad scar when she came. So we planned for a cesarean. And you're wondering where we'll put the incision because the umbilicus was in the lower segment. So doing all procedures, I'm sorry, we're planning everything, but she went for a vaginal delivery and saved us the problem. So the take-home messages for this talk is always remember Joel Koch and blunt entry is anytime better. A low transverse incision should be considered even in an obese patient unless morbidly obese. Routine creation of a bladder flap should be discouraged. a low vertical uterine incision should be considered for a preterm delivery with a well-developed lower segment. And for a transverse lie with a back down, consider a vertical incision, and for placenta accreta. And remember to always extend your uterine incisions, that's the hysterotomy incisions, in the cephalot goddard direction rather than transversely. There are no randomized trials to support or refute the use of tocolytic agents or instruments to facilitate an infant birth at the time of a difficult cesarean section. And for a deeply impacted head delivery, the reverse breech technique or the Putworthen's technique seems to be much better. But remember, cesarean section is always a team effort. It is not a single person who's going to do. The anesthesiologist, the neonatologist are an integral part of the care team, and they should all be familiar with the case before you proceed. It is a multi-member, intense, and usually short-term procedure, but in rare cases, it can last for several hours if complications arise, and the staff must be ready for this eventuality or should promptly transfer the patient to a higher level center. Always be well prepared with attention to details, because do the difficult things where they are easy and do the great things where they're still small. A journey of 1,000 miles must begin with a small step. So any small out of the way problem you're identifying should be tackled at once in a cesarean section. I want to thank Monica and Bhopal Society for the opportunity. Thank you so much.
You explained, ma'am, very beautifully all the cases. And as you said, that the preparedness is very important in cases of LSCS. When we are going to do it, first of all, prepare for the section, and even the things, if you are going to do the difficult cesarean section, then definitely we have a plan for the case. That will be a very good thing.
Because usually we are well planned for difficult things, and we
Yeah.
assume that we will not have a problem, and that is the condition you will get caught, because you will
Yes,
not be
ma'am.
prepared. We always think, oh, this is just a cesarean, primary cesarean, so baby is quite fine, will deliver, and some problem or the other will start. But when you're prepared for over-prepared, I'll say, with everything ready, the anesthetist, so backup also is available, a pediatrician is available, and everything you're prepared, because sometimes what will happen, the baby will look so fine in a CTG, but when you're taking it will be totally flaccid, and you will need a pediatrician to look after, and you will say, think, okay, let him come later, and you would have dared, and you cannot run between mother and the baby. That usually happens, that
Yes,
problem.
ma'am.
So always be well prepared. Never lose that that checklist. Whatever you have should be correctly ticked before you start. Never miss anything.
Yes, ma'am. You explained it very beautifully. Thank you, ma'am.
Thank you, ma'am. Thank you so much.
Wonderful job.
Your lecture
Yeah.
had so many
Yeah.
beautiful cases. I mean, I really enjoyed LSCS lecture. After a long time, I listened to every bit. And especially like the super obese patient, the description of the supraumbilical incision where you can, I still love the reverse breech extraction in deeply impacted head. I somehow never mastered the Patwardhan, though my seniors tried harder to teach me. And Suchitra ma'am has also joined. And madam, it was beautiful. Ma'am, I just wanted to ask, you had one baby whom you could not deliver properly because of a smaller incision. You you could not estimate that, make a decision. So when you're extracting that baby and the incision falls short, it's better to cut.
We had to do a T-shaped incision to take for the baby. We did a T-shape.
Right.
Ma'am, I like to ask one question.
Yeah.
If there are two babies, a twin pregnancy or a triplet pregnancy with one IUFD and one live baby, so is there any precaution we need to take while removing the?
No, then at delivery, nothing from our side. That all should have been sorted out by the fetal medicine specialist earlier itself. Like that IUD, all that problem they should have sorted out. Our problem is whichever comes early, we just deliver. But always be prepared for a PPH, because you got, it usually doesn't happen, very, very rarely that the thrombin material enters the maternal circulation from a IUD. So usually it will not be a problem. It should go on quite smoothly.
Okay.
Excellent talk, Charmila.
Thank you, madam.
And the thing is that never take things for granted.
Yes, ma'am.
You have to be very much ready. And another point is that when there is a floating head, when you are doing it electively and there is no fetal distress clear, like after putting the incision, you just
Wait for
stabilize
some
the
time.
head and just allow the fluid to let out. Then automatically the head will come on the line, and then you can easily.
Yeah, should not
hurry to hold
and try to take it out.
Yeah.
Ma'am, one more question I want to ask.
Yeah.
As you
yes, madam.
all experienced people are here. Ma'am, do you give injection oxytocin in floating head? You start before taking out the baby?
No, never, never. No,
Never.
never. You take out the baby only when the anterior shoulder is born, you can give oxytocin. I've seen some anesthetists say like I will give it earlier, but I tell them like don't touch that near me because I will not allow that oxytocin. Because suppose you are delaying the delivery and you're given oxytocin, it can cause complications in the baby at any time. No, you should not do that.
Yes.
Make
They
the
think that
delivery much more
contraction will be
difficult.
better and all that, but I don't accept. I don't accept that. So once the delivery happens, then only oxytocin will be given, not before.
Ma'am, there was a talk that it makes the delivery of the baby easy when there is a uterine
That's what the anesthetic.
and,
Yeah. There was one study, I think, which the anesthetist also quoted to me saying that I will start the oxytocin while you are delivering the baby and it will help in the placental separation and you'll have lesser of PPH, he said. I said, I don't want that risk. Suppose I've got a problem, it's a previous cesarean and I'm having a problem with releasing the additions and taking the baby out. And suppose you're given an oxytocin earlier and it has caused a contractile uterus and suppose baby goes for a uterus goes for a hyperstimulation or something like that, I'm adding to the problem there. So why should I wait?
Yes.
And I can stop that bleeding after I deliver the baby. The placenta is in my hand now. I can do whatever I want in a cesarean. So why should I rush there?
Yeah.
There are people who are using
I
even
don't accept that study. I don't know.
misoprostol before
I know.
giving the.
Yeah. You can see you can actually have no problems with whatever you do and nothing you do also you'll have problems. So why add on when you know that something will happen? That's like taking a risk to see what will happen. So that you should not do as a clinician at any point of time. There's no acceptance in any guideline that you give misoprostol. That is for an induction I can accept, not for placental expulsion you give a misoprostol or an oxytocin. That should not be done at all. That means you're going to compromise the blood supply to the baby by doing that. That should not happen.
Now comparing that, giving that earlier and after, how much of blood loss that is avoided? No study like that. No study.
Madam, that study did not say much also. It did not
yeah.
improve it so much. So,
that is why. That's why. Yeah. Welcome, Dr. Suchitra.
Good evening,
Hi. I was
Good
just listening to this and I fully agree with Charmila. Please don't give, people are in the habit of giving even carbitocin at the uterine incision till the baby is out, anterior shoulder comes out, remove that baby and then give. It is better to wait than to have problems.
Yes.
Nowadays they give traffic.
That is okay. That is accepted, madam.
That is
better. Even 1 hour before the season, it's not a problem.
But this is a uterine contractile agent, no, madam. So how much it will compromise a placental blood flow, we don't know, no. So
absolutely.
I'm really thankful for the great talk by Dr. Charmila ma'am, and nobody could have done it better than you, madam. I'm very, very sure. And the discussion which followed had all our, stalwarts speaking. Dr. Revati ma'am, her inputs, Dr. Charmila ma'am clearing the doubts and all the discussions. And of course, respected Dr. Suchitra Pandit ma'am has come. And ma'am, we welcome you with all our heart.
I would like to wish you before I leave, both Monica and Deepthi, all the best from our side. Best wishes.
Thank you, ma'am.
Thank you so much, ma'am.
Thank you.
And, Charmila ma'am, if you could stay for 2 minutes for...
no, I'm staying back. I just want to wish you before madam takes over. Yeah.
I take great happiness in introducing Professor Dr. Suchitra N. Pandit Madam as our chief guest for the evening. We are so honored, ma'am, by your presence and thankful to you for accepting our humble invitation. Madam is past President Foxy, Senior Consultant at the Department of OBGY, Surya Group of Hospitals, Mumbai. Foxy representative to CEFOC 24 to 26, Associate Member FIGO Ethics Committee 23 to 25, Chairperson AICC RCO.
Monica, बहुत हो गया अभी पढ़ते रहोगे तो टाइम ही निकल जाएगा.
Ma'am, can't wait to hear you. We would like to have your words of blessings, ma'am.
Right. So I think this is the Symbiosis episode 2 that you're doing.
No, I think we have already completed 16 webinars, ma'am. This we are
but
Symbiosis, just
You're
now.
winding it up. Okay. Because I was a part of one of the symbiosis. No, but good that you've chosen a very, very important subject like cesarean section. And, I'm sure, when you have people who are doing things day in and day out, they're able to give you the words of wisdom. So it's important that, these, messages go across to the people. So it's a good method. And today, I think with webinars, you were able to reach out to many different places. So congratulations for having chosen this particular subject, and all the best. I think today your elections have started today already. So you, and there's somebody else also contesting from your side. Who
Madam,
else is?
myself, Deepthi.
You're also there. Okay. From Jabalpur.
Jabalpur. Yes,
Right.
ma'am.
So both of y'all are, yeah, good. So one is for the quiz and one is for the practical obstetrics, right?
Madam, perinatology.
Perinatology. Closely related subjects. Right. Good. So all the best to both of you. And it's good that both of you all have come together and you are doing this program. And as I said, elections are, somebody wins, somebody loses. Nobody has a hard and fast formula for winning. But just because somebody wins doesn't mean that person is the best. Just because somebody loses, that doesn't mean that person is bad. It's just a number game. But I wish both of you the best. If you all win, fantastic. Nahi hua to don't worry too much. There's always another time to try. But the efforts that you all are putting in to get forth these programs, I even heard that your Bhopal conference, ISAR conference, you played a major role and you did a very good job. So, Monica, congratulations for that. And Deepti, I know, of course, is active in Jabalpur society. So, see, this is what we want. We want young, young people to come forward and work. And I'm sure, you will get elected. Nahi to, we always have another time. So don't take this as a mark of your future, but keep working. That's most important. And thank you so much for inviting me, and very creditable that you've done so many webinars under that Symbiosis heading. So wonderful work done. And congratulations to all the office bearers. I'm sure Dr. Jaideep and Dr. Madhuri would have been there right in the beginning. But happy to see Revati, and I didn't get a chance to see the other speakers. But good to see, good to see that everybody is coming together for a webinar, and it's like a scientific platform. You're sharing knowledge and experience. Thank you very much, Monica. And I'm sorry I'm late. There was another conference going on, and I had to come from there and then just go to the clinic. So a little bit of a hodgepodge, but okay, all done.
Thank you so much, ma'am. Even like whatever time you have joined, you have made the program more beautiful, ma'am. Very graceful.
Okay.
And we are indebted to you for your presence. We really are.
Thank you so much. Thank you.
Thank you for your wishes, ma'am.
All the best.
Thank you so much. Thank you so much.
All the very best, Dr. Monica and Deepti. I have
Thank
another
you so much, madam.
Okay, thank you.
Thank you, Suchitra, madam.
Thank
So,
you. Yes, ma'am. Thank you all. Now we will move ahead, and there is slight change in our program because Dr. Girja Wag ma'am is stuck in traffic. She will be taking the third session. Our second session is by Dr. Monica Singh ma'am. She will be talking on antenatal interventions to improve perinatal outcome. And to chair this session, we have three chairpersons. Dr. Aditi Rathod ma'am, she is Secretary Ratlam OBGYN Society. Dr. Rekha Singhal ma'am, she is Secretary Riva OBGYN Society. And Dr. Rupali Maheshwari madam, she is Secretary Ujjain OBGYN Society. Dr. Aditi Rathod ma'am is Secretary of Ratlam OBGYN Society, Consultant Rathod Nursing Home, Jaora, and certified in hospital management. We welcome you, ma'am, to chair this session. Dr. Rekha Singhal ma'am, she is owner of the Tanisha Hospital Riva and also member of IMA and Foxy. As a society member, she has won many awards, and including the Mela Smriti Award in 2022, Duru Shah Award, Special Award for Cervical Cancer, Gangadharan and Chitrahara Award for Preventive and Research Oncology in 2024. She has many presentations many presentations. We welcome you, ma'am, to chair the session. Our next chairperson is Dr. Rupali Maheshwari, madam. She is Foxy trained in ultrasonographer and consultant at Pushpa Mission Hospital. She is in private practice for more than 15 years. She is also Foxy trained ultrasonographer. We welcome you, ma'am, to chair the session. Now I hand over the session to our chairpersons to introduce our speaker and carry forward the session.
Chairpersons are not there.
No, they are there, ma'am.
Doesn't matter. I think Dipti can introduce.
Yes,
Dipti?
ma'am, absolutely.
Right.
Delight and pleasure.
Thank you.
Uh, So Monica Singh ma'am, who's formerly MS, DNB, FMAS, FICOG, CIMP, also consultant reproductive medicine at Bhopal Fertility and Test Tube Reproductive Medicine Center, a professor at Ellen Medical College, Bhopal.
That's all. That's all. Dipti, that's all.
Ma'am,
No,
ma'am,
it's
just
okay.
one personal word. Despite being in private sector, a very hardworking person with great academic inclination, a regular presenter and participant at Eshere, and a very loving personality who leaves no stone unturned in, once she decides. So best wishes to you, ma'am, for the ongoing elections. And thank you so much for making me part of I think this is my third probably participation between the Symbiosis and Perfection series. So thank you so much. It's always been a great pleasure and learning experience. And my humble regards and greetings to the esteemed chief guest, Suchitra Pandit, madam. Thank you so much, ma'am, for your kind wishes. And our guests of honor, Revati Janki Ram, madam, and Kiran Kurtakoti, sir, for their wishes and blessings. And my greetings and regards to all dear friends and colleagues from Madhya Pradesh. And we look forward to continued academic work, like Suchitra madam said, that irrespective of the outcomes, just being together and working together is probably what should be more important. So thank you so much. Welcome, ma'am, for your talk. Looking forward.
Thank you for the kind introduction, Dipti. It's always beautiful talking to you. And you yourself are a very beautiful person. That is why you have spoken such nice things about me. Otherwise, I'm a very small entity in Madhya Pradesh. So we will, with the permission of the chair, I will start sharing my screen. And this is an extempore topic because Parag sir could not join. But I think this goes with the scheme of things because we definitely need some interventions in order to improve outcome as far as the perinatal outcomes are concerned. And this is also the committee for which I'm contesting elections. So I had special, I was partial to this topic and I went through a lot of guidelines in order to come to formulate this talk. So it was WHO in 2016 who gave us an overview of how antenatal care should be in order to improve the perinatal outcomes, the mother and the child. So this guideline took into account the reproductive health and research. These are big organizations, Nutrition for Health and Development, Maternal Newborn Child Adolescent Health, WHO, and the Human Reproduction Program. So I'll, in the next 20-25 minutes, I'll be going through the background of the talk, how the development of the WHO ANC guideline was done, what does it recommend, what is new about it, and how is it different from the previous guideline, and how does it carry out the implementation of the program, research, monitoring, and evaluation. The background of the talk says that antenatal care is critical, and this can only be done when there are timely and appropriate actions which are evidence-based. And these should be related, as we've studied in our PSM, these should be related to health promotion, disease prevention, screening, and treatment. So our ultimate aim is that it should reduce complications from pregnancy and childbirth. The good antenatal care should definitely reduce the stillbirths and perinatal deaths, and it should give an integrated and personalized care of through delivery and throughout pregnancy. Previously, WHO had come out with a 4-visit antenatal care model, which involved specific evidence-based infant interventions for all women, and this had to be carried out at 4 critical times in order for the woman to be into the program and following it. And this was also known as the focused antenatal care model, and this was part of pregnancy, childbirth, postpartum, and newborn care, all integrated into one. So, what WHO envisioned was a world where every pregnant woman and newborn receives quality care throughout pregnancy, through childbirth, and also in the postnatal period. And she has a positive pregnancy experience by prioritizing person centered health and well being and her own autonomy. So, there should be quality throughout the continuum of care. We should aim towards reducing mortality, morbidity, providing respect to the woman, take into account her own views, and optimize your service delivery within the country that the health systems are operating. So, what are the women's views and how should they be respected? We are battling so much of trauma in India right now, from the death of a postgraduate doctor in Kolkata. So, this is how a woman's views have to be taken into account every time. That was an extreme case, but even pregnancy, there should be a positive pregnancy experience in antenatal care. There should be a healthy pregnancy for mother and baby. We should be able to treat all the risk factors, take into account any illness, even death, physical and socio-cultural normality during pregnancy. She is pregnant, it doesn't mean that she is away from the socio-cultural fabric of the family and the society. There should be effective transition to positive labor and birth. There should be no trauma or stress to her. And she should develop positive motherhood feeling. That is a lot of self-esteem, competence, and autonomy. So, for this, you have to have a lot of medical care, emotional support, and advice. The development of this guideline was the 2016 ANC guideline core package that every pregnant woman, even adolescent girls, should receive. And the flexibility should be there according to the country where it is operating. Like in every country, there is a different sort of social package which is given to antenatal. In India, we have a different sort of, family structure. It is the mother-in-law who brings the daughter-in-law who's pregnant to the PHC or the CHC or the private facility. So we have to take into account that social fabric of the particular country before we impose the guidelines, or rather ask the health facilities to follow the guidelines. And definitely, we should have evidence-based practices during antenatal care, which can lead to a positive pregnancy experience. The work streams for this guideline evidence synthesis could be divided into individual interventions and system interventions. The individual interventions dealt with antenatal testing, and there were barriers and facilitators which were identified in order to provide access to and the provision of antenatal care. And the health system interventions were the large scale WHO ANC model, which was earlier the 4-visit type of visits and the framework. So, this guideline, the earlier guideline of WHO, had 3 technical consultations with the GDG, or the Guideline Development Group. And this was a collaborative effort between WHO and various health departments, methodologists, statisticians, and experts. This was done under in the context of rigorous research with targeted monitoring, evaluation, and some guidelines were given. I'm sorry. What I meant to say was that some guidelines were only given in the context of rigorous research. They were not uniformly applied to everyone. Second sort of guidelines were those with targeted monitoring and evaluation, and third only in specific contexts. And there were some guidelines which had to be recommended as an option to every patient, second to be recommended only under certain conditions, and third type of which are not recommended at all. So 49 recommendations were given about antenatal care, which were grouped into 5 topic areas. A was nutritional interventions, and these interventions given by the GDG were 14 in number. Number 2 or B was maternal and fetal assessment and how it should be carried out. These were 13 in number. C 7 were the preventive measures. 6 were interventions for common physiological symptoms like nausea. And lastly, the health system interventions which should be carried out like the blood test in order and ultrasound to improve the utilization and quality of antenatal care. These were 9 in number. So these are all the interventions and how they were grouped. Detailed methodology was provided for synthesizing and assessing the different types of evidence and their benefits, harms, the resources required, acceptability in that country, feasibility. Like in a small hospital, you cannot have 2, 3 ultrasound machines. So the ultrasound machine was used by various departments. Then there was a remarks section, implementation section. Direct links are provided so that the operator sitting in that hospital can, access the WHO guidelines. Then these recommendations are mapped to the ANC model of 2016 for optimal timing. And it is not actually a clinical practice manual. These are just the guidelines. The clinical practice has to be done according to the WHO clinical practice manuals, which are separate and different for different countries. So this is how the guidelines are there. They are available on the net. Like these are whole pages where you can go through the dietary, the health practitioners can go through the dietary interventions, intimate partner violence during pregnancy. So this is how the guidelines have been developed. And I'll just be speaking about the key features. Number one and most important are the nutritional interventions. And here it's recommended strongly that the pregnant woman is counseled about healthy eating habits and keeping physically active during pregnancy in order to stay healthy. And she has to be discouraged from gaining excessive weight during pregnancy. Now, in the context of those populations where there is undernourishment or less of food available, the nutrition education should focus on increasing the daily intake of energy source and protein intake. And there should be a balanced energy and protein dietary supplementation. But at the same time, the woman should not be, uh, told to take too much of high protein supplementation because number one, it will be costly to her. She'll not be able to afford it, the family. And third, it might not be very palatable to her. The aim for the nutritional recommendation is to prevent the risk of stillbirths and small for gestational age neonates. Coming to the part two of nutritional interventions is the iron folic acid supplementation. The strongly recommended recommendation is a daily iron intake of 30 milligram to 60 milligram of elemental iron and zero point 0.4 milligram of folic acid. This aims to prevent maternal anemia, puerperal sepsis, low birth weight, and preterm birth. But in some countries, where the pregnant woman is not accepting daily iron due to side effects, and the anemia prevalence of that country is less than 20%, you can even recommend an intermittent oral iron and folic acid supplementation wherein 120 milligram of elemental iron and 2.8 milligram of folic acid is given weekly to the pregnant woman. Similarly, low dietary calcium intake, which is there in India, we recommend 1.5 to 2 grams of oral elemental calcium daily. This also greatly reduces the risk of preeclampsia. And vitamin A supplementation is only recommended for those areas where the deficiency is endemic and a public health problem. Zinc supplementation only in context of rigorous research. Multiple micronutrient and costly supplementation not recommended. B6 or pyridoxine supplementation not recommended. Vitamin E and C supplementation not recommended. D supplementation not recommended. So these are the things you have to avoid doing when you're working in a large population in Indian setting. And for those pregnant women who are taking a daily caffeine intake of more than 300 milligram per day, they have to be counseled that this has to be reduced because you will incur a greater risk of pregnancy loss and low birth weight neonates. Coming to maternal assessment is again context specific recommendations. They are not a blanket recommendation. Full blood count is the CBC is the recommended method for diagnosing anemia in pregnancy. But in those settings where this facility is not available, on-site hemoglobin testing, simple with a hemoglobinometer, is recommended over the use of complicated tests as a method of diagnosing anemia. Similarly, the ideal method is midstream urine culture as a recommended method for diagnosing asymptomatic bacteria in pregnancy. But in settings where this is not available, on-site midstream urine gram staining is recommended over the use of dipstick methods for diagnosing infection in pregnancy and should be treated. And at the same time, you should use this opportunity to do a gentle inquiry about possibility of intimate partner violence so that if you catch it, you can, counsel the family and maybe refer the patient to an appropriate facility and save her from all the trauma. Now, hypoglycemia in pregnancies, volumes are being spoken, many webinars are being done about hypoglycemia in pregnancy, and there's going to be new recommendation wherein in first trimester you test and you label the patient as GDM. So hypoglycemia first detected at any time during pregnancy should be classified as GDM or diabetes mellitus in pregnancy using the WHO criteria. Tobacco use has to be discouraged. Even secondhand smoke has to be discouraged. And similarly, substance abuse, alcohol intake, the patient, the pregnant woman has to be counseled. In those settings where HIV is rampant, you should have a package of testing for HIV along with integrate the test with syphilis, viral, and other key tests. And where tuberculosis is prevalent in certain settings, and the prevalence of the disease is too much, active screening of tuberculosis can also be done. This also takes into account a lot of countries in sub-Saharan Africa where these guidelines are also based. Coming to fetal assessment, daily fetal movement count is only recommended again in context of rigorous research because it is said to give a lot of stress to the patient, the counting, and it will interfere with her sleep and daily work. So this is actually not imposed on any woman. And replacing abdominal palpation with symphysis fundal height is not recommended. You use the clinical methods for palpation as you are used to, you have been trained. Routine antenatal cardiotocography is not recommended to improve maternal and perinatal outcome. And one ultrasound scan before 24 weeks of gestation, preferably in the first trimester, is strongly recommended because this will not only estimate the gestational age, the healthy growth of the baby, detection of multiple pregnancy, fetal anomalies, and this will also, help to give a positive uh, impression of the pregnancy clearly to the mother and improve her pregnancy experience. But at the same time, you do the ultrasound, routine Doppler ultrasound is not recommended to improve the maternal and perinatal outcome. In case you find asymptomatic bacteriuria, a 7-day antibiotic regime is recommended for all pregnant women, and this also helps later to prevent preterm birth and low birth weight. And antibiotic prophylaxis is only recommended to prevent recurrent UTIs. Otherwise, you don't give antibiotic prophylactically to any woman. Similarly, antenatal prophylaxis with anti-D immunoglobulin in non-sensitized Rh negative women between 28 to 34 weeks of gestation is only recommended by WHO in the context of rigorous research and not routinely recommended. In endemic areas, you can give anti-helminthic treatment in the first trimester. And TT vaccination, of course, is recommended depending upon the previous TT vaccination exposure to prevent neonatal mortality from tetanus. In malaria endemic area, especially Africa, they use intermittent preventive treatment with sulfadoxin pyrimethamine, and this is the doses are repeated in order to prevent the high grade fever and malaria. And in those areas where HIV infection is common, these women are even given oral pre-exposure prophylaxis of a dose containing tenofovir and disoproxil fumarate. TDF is the drug which is given as an oral prophylaxis. For the common physiological symptoms that the woman might suffer in the first trimester and early second trimester, it is highly recommended she takes household things like ginger and chamomile, vitamin B6, acupuncture is also recommended because anything which can, make her relieved from the nausea of the early pregnancy, depending upon the family's preference, the woman's preference, the eating options available to her. Similarly, diet and lifestyle recommendations in order to make her comfortable to relieve the heartburn in pregnancy. And antacid preparations can also be offered where the symptoms are troublesome as far as acidity is concerned. Similarly, magnesium, calcium, and non-pharmacological treatment options for the leg cramps can be given to the woman. Regular exercise is strongly recommended to prevent the low backache, the pelvic pain, and other options like physiotherapy, support belts, acupuncture, if like the WHO doesn't say no to that. Similarly, to relieve the constipation, encourage her to take wheat bran, other fiber supplements rather than to use laxative. And to treat the edema of pregnancy and varicose veins, you can use non-pharmacological options like compression stockings, leg elevation, massage, and water immersion, which are easily available in every household. The health system interventions to improve the utilization and quality of antenatal care. WHO recommends that every time the woman goes to the health facility, she carefully carries her own case notes in order to improve continuity of care, quality of care, and the health care provider knows about the previous visit. And she also can follow her pregnancy experience throughout the 9 months. The midlife-led continuity of care models is popular in some countries, and in India also we have the ASHA workers and the Anganwadis, where a small group of known midwives support a woman throughout the antenatal, intrapartum, and postnatal period in a continuation. So the woman becomes more and more familiar with them. In some places, WHO has advised group antenatal care because the pregnant women are, being treated together. They can talk to each other, provided the infrastructure and resources for delivery of group antenatal care is available in that health facility. There should be implementation of community mobilization through facilitated participated learning and action of PLA cycles, again in women's groups. And there are certain interventions where that include household and community mobilization, and home visits are encouraged. It's not necessary that she only has to come to the hospital. The health worker can also visit the woman at home. Task shifting, the promotion of health related behaviors for maternal and newborn health to you have to delegate the work to health workers, to auxiliary nurses, midwives, and doctors. All of them, they share the work. Similarly, you have to take care of the endemic problems like malaria, and policy makers have to basically, if you have to apply WHO regulations in your country, you have to have the educational facility, regulatory authority, finances, personal support, social workers, professional support, because adequate number of health workers who are adequately educated and trained have to be recruited, then sent to rural areas and remote areas where they will work, and they have to be paid well so that they do not leave the job. So now the antenatal care models of WHO recommend a minimum of 8 contacts. It is not called visits. These are minimum of 8 contacts which are recommended in a pregnant woman in order to reduce perinatal mortality and improve her overall experience of childbirth. So what is so new about this 8-point care? The GDG recommendation was informed by this change happened because GDG, or the Guideline Development Group, found that the 4-visit ANC model of WHO, which was prevalent earlier, it was associated with increased perinatal deaths. Now, they also found that if they increase the number of visits or contacts, there was improved safety during pregnancy because of the increased frequency of maternal and fetal assessment, which was given to every pregnant woman. There was also improved health system communication, data monitoring, and support, which was given throughout pregnancy. There was also more contact between pregnant women, and the healthcare workers were also subsequently trained to be respectful and knowledgeable and educated and trained. But when these contacts were increased from 4 to 11 or 15 contacts, it did not make any difference in the maternal and perinatal health outcome. So that is why they came to an optimum number of 8. So this is the left side shows the WHO FANC model, which was prevalent earlier with the 4-visit model. In this model, the visit 1 was in the first trimester, 8 to 12 weeks. Visit 2 was 24 to 26 weeks. Visit 3 was 32 weeks, and visit 4 was 36 to 38 weeks. But now the 2016 model of WHO has made the 8 contacts. So they are not called visit. The term used is contact. The first contact is before 12 weeks. second contact at around 20 weeks, third contact around 26 weeks. Before the third contact, the patient should have one ultrasound. And then you can see there is contact number 4, 5, 6, 7, 8, which are almost 3 to 4 weeks apart till 40 weeks. The frequency of interaction has increased and she returns for delivery at 41 weeks if not given birth till then. So the guideline uses the term contact because contact implies active connection between pregnant women and the healthcare providers, which is not the same as visit. And in terms of operationalization of the recommendation, contact can take place either at the health facility or at the community level in the woman's home. Contact helps to facilitate context-specific recommendations like interventions against diseases and health system task shifting. So what about ultrasound? Definitely an early ultrasound before 24 weeks is recommended for all pregnant women. This is recommended for all pregnant women in order to estimate so many things about early pregnancy and enhance the maternal pregnancy experience. An early ultrasound, especially if you show the baby's image to the mother, it gives her a lot of positivity and encouragement to, take care of herself and take care of the pregnancy. Now, an ultrasound scan after 24 weeks or late ultrasound is actually not recommended if the woman has had an early ultrasound scan. But the stakeholders or the health facility should consider offering the second trimester or late ultrasound scan to those pregnant women who have, for some reason, missed the early ultrasound scan. Similarly, the ultrasound equipment is costly, so this can be used even for obstetric emergencies. You can shift your machine to the OT, or you can use it in the labor room, or use it. It can be used by other medical departments like the Department of Surgery or Medicine. And the implementation and impact of this recommendation depends upon the place that you're working, the region, the country. The overarching aim of the ANC model is to build a positive pregnancy experience. And as we spoke earlier, to provide the pregnant women with respectful, individualized, and person-centric care at every contact, the 8 contacts, with implementation of effective clinical practices in the form of nutritional interventions, pharmacological interventions, blood tests, urine tests, and provision of relevant and timely information to her. Psychosocial emotional support, group, training, and group classes. Practitioners with good clinical interpersonal skills develop the soft skills of your, trainers, about your health workers in a well-functioning emotionally strong health center. So the effective implementation of antenatal care requires that the health system approaches and strengthens continuity of care, provides integrated service delivery, improves communication and support to the pregnant women, makes supplies and commodities easily available, and empowers the healthcare providers, because the workers are the healthcare providers, the people who will go to the periphery and work. So you have to recruit them as well as retain them, pay them well, educate them, and capacity building. The knowledge has to be implemented and disseminated. So I'll not go into the details. It's a very long lecture. So you have to basically adopt, adapt, and implement the ANC model, the core packages, as I told you. And at the same time, when you are adapting an implementation to implementing it at a particular country level, you have to monitor and evaluation the practices continuously. And some indicators have to be developed, some research questions have to be answered. You have to go through policy briefs, interactive websites. A lot of computers and everything is required. AI is required if you want this program to go forward. There should be regional dissemination workshops. The guidelines have to be translated into so many languages, the regional languages, local language, and of course is the role of educational webinars and all the educational matter. So these are all the guidelines and how they have been disseminated throughout the Southeast Asian region and the African subcontinent. And this is how the links work. And you can see it being operated in Africa, in India, in the Middle East. And the aim is to basically build a positive pregnancy appearance. These are all the guideline contributors. It's all available on the net. And as spoken by, as statement has been given by Ban Ki-moon, our UN Secretary General, to achieve every woman, every child vision and the global strategy for women's, children's, and adolescent health, we need innovative, evidence-based approaches to antenatal care. I welcome these guidelines, he says, which aim to put women at the center of care, enhancing their experience of pregnancy and ensuring that babies have the best possible start in their life. Thank you very much. And I seek your humble blessings, humbly seek your blessings for election to the post of chairperson, Foxy Perinatology Committee this year. And the voting has started today. I need your vote and support. Thank you.
Thank you, ma'am.
Good evening, Girja ma'am. Neetu, we can go ahead, I think. Purva?
Yes, ma'am. Now moving the session forward, we have next session by our Vice President Foxy ma'am, Dr. Girja Wag ma'am, on postpartum hemorrhage. To chair the session, I invite Dr. Deepti Gupta ma'am and Dr. Jagriti Kiran Nagar ma'am. Jagriti ma'am has not joined because of some emergency. So I request Dr. Rupali Maheshwari madam to chair the session. Dr. Deepti Gupta ma'am, she is presently Secretary MPOX, past President, Secretary Jabalpur OBGY Society. She is presently Foxy Quiz Committee West Zone Coordinator, Foxy Gurukul Medha West Zone Coordinator, peer reviewer of Jogi and NCE Jogi, co-editor Foxy Focus on recurrent pregnancy loss. She is also
Purva,
active member.
Let us move on. Good evening, Girija ma'am.
Next, can I have CV of Dr. Rupali Maheshwari madam? Dr. Rupali Maheshwari ma'am, she is presently Secretary of Jan OBGY Society. She is Associate Professor, Foxy trained ultrasonographer and consultant at Pushpa Mission Hospital. Her special area of interest is in infertility, recurrent abortions and high-risk pregnancy. We welcome you, ma'am.
Good evening, everybody.
Now I hand over the session to chairperson to introduce our speaker, Madam Dr. Girja Wag, ma'am. We welcome you, ma'am.
Thank you. I think we
Purva,
will not
can
be...
Ma'am, just 1 minute, please.
Okay.
It's an absolute pleasure and delight to have you with us once again. I think you are one of our favorite speakers, and for a formal introduction, Madam is Professor and Head at Bharati Vidyapeeth Medical College, Pune, and a Senior Consultant at Cloud9 and Apollo Hospitals, Pune. She's been the chairperson of Medical Disorders in Pregnancy Committee, Foxy, and also Vice President of India Chapter Gestosis since 2014. And it's really always so enlightening and encouraging to hear your talks, ma'am. And we have been waiting to hear your talk. And I think regarding PPH, I just came across this quote that third stage is a fairly unforgiving stage of labor, as in it there lurks more unheralded treachery than both first and second stages combined. And I think PPH is one such topic where there is so much of ongoing, and each one of us, whosoever has ever encountered PPH on table, we know how frightful and scary it is to control that bleeding as early as possible. So we are really looking forward to your talk, ma'am. Thank you so much.
Thank you, Dr. Dipti, for that very kind introduction and setting the stage for PPH and appreciating me so much. And I really understand that when you have so much of appreciation, it comes with a lot of responsibility. And I have decided to take that responsibility. And actually, I decided, I don't know why my screen is not showing what it has to show. Am I having a problem? Wait, I'll just open my presentation. That is one. And the second thing is, yeah, I got it. The second thing is that, I was little busy because we had a very massive rally here in our university medical college, sort of condemning what has happened in Kolkata. And
Yes,
therefore,
ma'am.
I requested for a shift because I had to rush then, from there and here and all that. So sorry for, tripping your schedule. And I also pay my respects to Dr. Rupali Maheshwari, who has agreed to chair this session at the last moment. And Monica, it's very difficult to say no to whatever you are request for. And therefore, here I am. And you told me to speak on PPH, and I decided to take it to speak only on the golden first hour. Because in our country today, with varied kinds of medical facilities available across the country, it is the golden first hour, which is the most important hour. If at all we are going to really have any results, it's going to be when we are able to tackle it at that time. So thank you once again for that introduction. And this golden first hour is a very important hour immediately following traumatic injury, as we understand. In trauma, it is used very commonly, in which medical treatment to prevent irreversible internal damage and optimize the chance of survival is found to be most effective. So that is why it is, and it also is to be used in parlance in our postpartum hemorrhage as well, because we see that time truly matters. Now, it's very important to understand, and we cannot leave the perspective of what is happening across our country. And we all know that we have a goal to reach of by 2030, that the maternal mortality ratio across the country has to be 70. Some of the regions in our country have been able to successfully achieve it already, but there are so many other reasons which are still diluting our statistics. And therefore, we have to be understanding, because one of the most important contributors for this maternal mortality ratio continues to be postpartum hemorrhage, and it keeps on hitting us in different ways. Let us look at as an example of here Mrs. SB, who had 5 losses, one at 24 weeks of gestation, which was a fetal growth restricted baby. She had SLE, 2 DNEs done, and a hysteroscopy done for incomplete products of conception. And currently, she had come to me with 12 weeks gestation with 12 weeks gestation, where her previous doctor had told her that you need to terminate this pregnancy because there are certain adhesion bands in your uterus. And then with such a bad history, she came to me. I told her, yes, you have a problem. You may land up in a problem as we go by. But if you are ready to take the risk, we will continue this pregnancy, because anyways, termination of this would also be difficult. And at 12 weeks, we had an access to doing her combined testing, which told us that the baby does not have any aneuploidy. And therefore, we decided to, with great heavy heart, continue this pregnancy. Throughout the pregnancy, this woman had 3 brisk hemorrhages. And then one day, when she reached the baby weight of 1 kg and 34 weeks, because there was now reverse in the end diastolic flow of the uterine, the umbilical artery, I said, let's plan your C-section. And on a Sunday, we decided to do it with all kinds of planning, because I was expecting things would not be really right. And yes, it was so. On table, we did a C-section, delivered the baby cried. There was a neurology team looking after it. And fortunately, I had called obstetricians to help me as well. And here it was. She did not have a placenta, which was at a location. The placenta was entirely present in the uterus, a global placenta. And you can appreciate the specimen of hysterectomy. We did an immediate hysterectomy, and we could do it because she started bleeding the moment the baby came out and the placenta started separating. When I put my finger inside posteriorly, I found that the posterior wall of the uterus was completely thinned out. And then we decided on table, her husband was sitting next to her. I said, we are taking out your uterus because I don't think it's pointless keeping it behind. And fortunately, they agreed. And there was a rider in which they also said that, yes, madam, you are our decision maker and you are our God. And that is a very difficult phrase to handle, I understand. But we were lucky. She bled quite a lot. We had to give her massive transfusion protocol, nearly 32 transfusions over 24 hours. But the patient survived, and you can see how bad this placenta looks. Sent it for histopathological examination, and it turned out to be placenta preta, as we had suspected. And this was something that we have to be always aware of. So what helped, and this baby is now 7 years old, and she's one of my success stories, and I'm very happy because when there are success stories, then we can share with them, and then we can learn also a lot of things and share the knowledge. So background risk assessment, strong index of suspicion, preparedness and planning, swift action to resuscitate and call for help, expertise, and preemptive counseling of the patient and the family all came into helping to survive this particular woman. So we have to remember, because with the rising placenta accreta scenario in our country, these surprises are still occurring on the table. And therefore, we should never forget care bundle 6 points, and remember that all cesarean section care, we should risk educate and talk and advocate about placenta accreta awareness, where there is a consultant obstetrician anesthesia, lot of blood available, multidisciplinary involvement and discussion, talking, being on the same page, teamwork is extremely important, and access to a level 2 critical care bed is essential. Now, in this particular situation, many times we have to land up doing what we call as a classical cesarean section. And you can see here that this is a patient who has placenta percreta, and a classical C-section is being performed, and with an information that the moment we take out your baby, we are going to do a cesarean hysterectomy. So that is always a simpler decision and a simpler approach to take. If that is amenable, it would be amenable, of course, if the woman has completed her, childbearing, and we are sure that this particular baby which we have delivered is going to be a little better, not a very tiny, weeny baby, which probably would be at risk of survival. And you can see here that a classical cesarean section is being performed, or sometimes you can quickly decide to do what we call as a uterine artery embolization preemptively, so that you are able to have, and this is access to the groin. It's always nice to have a cardiac cath lab we have in our center, and we are very lucky. So whenever we have such kind of patients, we can consider doing a uterine artery embolization. Of course, it's expensive. It will cost a lot to the patient. There's nothing freebie there. But then it can be some, it will help us to be able to salvage this particular pregnancy. And you can see here now that the baby has been delivered, and can you appreciate that this placenta accreta is so, and quick, swift approach is very, very important. No attempt is to be made to separate that placenta. There are a few of our colleagues who are now mentioning that we can assess the placenta and then maybe squeeze it out and try to do something. But if it's a percreta or an increta, it's next to impossible. And therefore, you can see quick ligations are done, and then you would do a hysterectomy. So we are very lucky if this can be done, but sometimes we may have to go through the bladder, to do that. So all these things, it's always better to wisely do priori mapping and then take your calls. And many a times this can help. There have been times when in a premature patient, we have done the placental squeezing technique and then salvage the uterus, but that would be only in a premature. You can see that here the baby was a term baby and the woman had agreed to a hysterectomy. So that's the reason why hysterectomy was undertaken. And you can see that both the uterine artery are embolized here. And then after that, it's always better to do a hysterectomy, as you can see here in the picture. So I'll go ahead. Now let's look at a case scenario. A woman had a normal vaginal delivery. She had postpartum hemorrhage. Uterotonics and tranexamic acid was given. Bleeding continued still. Examination under anesthesia was done. There was found to be a trauma which was accessible. Then you can consider doing a simple corrective suture and maybe packing. Packing is something that obstetricians really love, and it helps. And if it is inaccessible, maybe you may consider an embolization or an aortic compression or a laparotomy. And if there is no trauma, then maybe it is atonic PPH and coagulopathy is probably started to set in. Put in a uterine balloon tamponade, and then we have to constantly look at the various keys to appropriate initiation of therapy. When the PPH starts vital affecting anemia, preeclampsia, you have to remember that in these patients, even if little blood loss, they will get exsanguinated. If the duration of labor has been more than 24 hours, it is highly likely that it is atonic PPH, and these difficult labors are a menace sometimes. Why is there blood loss? If not atony, then trauma, post-labor dehydration also is a possibility. And then uterotonics given in the right dose and the right way, still the bleeding continues, then we have to be vigilant all the time. So whenever we look at the steps for the management of postpartum hemorrhage, Rapid assessment of hemorrhage through 4 T's is extremely important, where tone is 70% of the times, trauma 20, tissue, that is fragments remaining inside, can be about 10%, and therefore we have to get into the habit of looking at the placenta correctly. And thrombin, even if it is 1%, it's always a background thing that is happening. And therefore, all these 4 things can coexist. And therefore, we have to be extremely vigilant in that first 1 hour post-delivery. So the 3 important messages here are: if medical therapy using 3 to 4 uterotonic agents has not worked within 1 hour, there is no logical reason to think that it will work in the next hour. If compression sutures are delayed until the onset of coagulopathy, there is no reason to think that they will work unless the coagulopathy has been treated. And maintaining perfusion and oxygenation at all times is essential. So nothing is like one after the other. You have to always be parallelly working on all fronts, because remember, the time is running out. Now, most PPH-related deaths are preventable through the implementation of effective interventions. And today, if we look at the trends in the health facility deliveries across regions, we see that loads and loads of women are now delivering in facilities and not at home. Now, this offers us an opportunity to save these lives, but it also gives us a responsibility that we should not falter, and now we must deliver and not cause delays. Now, still, despite this, death continues, and the reason being that probably we have inconsistent and or delayed use of effective interventions for prevention and treatment of PPH. Systemic problems in the health services, such as lack of blood banks, inadequate staffing, has led to continued unacceptable rates of hemorrhage-related maternal deaths. For example, let's look at this particular insight from the tranexamic acid study, which was conducted under the woman trial. And what does it tell? That if you give tranexamic acid immediately, then there is 70% improvement of survival. For every 15 minutes delay, there is 10% decrease in the survival benefit. And after 3 hours, there is no benefit. Now, I'm saying this because so many times we receive patients who have been subtreated or not treated at all, exsanguinated, coming to us. It's very important that these realizations are, and there are interventions now, there are medicines now, which have to be judiciously used. So now let us look at one more instance. A junior resident delivered a macrosomic fetus and identified multiple cervical, vaginal, and perineal tears. After spending approximately 30 minutes, keep on looking at the time that I'm talking about here. After approximately 30 minutes suturing a few of the vaginal lacerations, she realized that she needed an experienced obstetrician to complete the complex repair. The lecturer came in and she said she has a tear of the anterior cervix at the intersection with the vagina, a few deep vaginal lacerations, and a 4-degree tear. The uterus is well retracted and the abdomen is not distended. As she begins the repair, there is diffuse ooze of blood from all areas of vagina and perineal trauma noticed. Cervical laceration is sutured, but bleeding continues from the closed laceration. So now what has happened? Itna time chala gaya. What happened? Coagulopathy set in. So lacerations are always complications of the first and the second stage of labor. Cervix the first, and vaginal and perineal the second stage of labor. After that, you deliver the placenta. Then you see everything, and then you just imagine how much time has gone, and she has continued to bleed. What could help? So it's very important to have certain useful tips to remember. A 14-gauge IV line compared with an 18-gauge IV line over the same time period delivers double the fluid volume. Simple things that we must know. These are some useful tips. And most importantly, while we were struck with COVID, the WHO came up with various stakeholders with this PPH bundle. After IMCL, what next? So if despite you practiced your IMTSL, still the patient bleeds, immediately call for help and do the first response actions. And what are these first response actions? IV fluids, uterotonics, tranexamic acid, and uterine massage. So during labor, at least one IV line in women at risk of PPH. And if a woman is at very high risk, then put in a second IV line. 1500 ml blood loss can be well supported by crystalloids, while colloids have no role, if at all, only 500 ml NS or RL. No D5 or no DNS. You can give 1 liter as well. But usually we have those 500 ml pints. And once you start fluids, keep charting it because you should not overload the woman. But many times nowadays, with fear of pulmonary edema, many times there's a huge amount of underloading that is being undertaken. So whenever we are looking at this role of fluid resuscitation in the treatment of PPH, blood loss is generally underestimated, both in volume and rapidity. Women initially compensating well for losses because of their good health and the hypovolemia of pregnancy, concern that over-resuscitation leads to pulmonary edema, and failure to appreciate the dynamics of fluid shifts in the body is what is the challenge that we usually face. Another very, very important thing that we can use here, and this is something which we have in our EMD as well as in our labor rooms. And this is the non-pneumatic anti-shock garment, which I recommend here that each and every labor room in our hospital, in our entire country, has to have this. Now, it's not a very expensive thing, but the moment a patient starts bleeding, we also put it for obese women where we are doing elective C-section. While we are transferring patient from the labor room to the operation theater, we are using this. We are also using this particular non-pneumatic anti-shock garments prophylactically in patients of placenta accreta whom we are delivering, because we want to ensure that they don't get exsanguinated. What happens when you are putting this non-pneumatic anti-shock garments? The most important action is the blood supply to the brain, heart, and the lungs remains. Now, if they are perfused well, they will function well, and therefore women will not go into dire consequences of shock. And after resuscitation, she has chance of good survival and less morbidity. How to assess blood loss is another challenge. Blood loss is usually evaluated indirectly by assessment of vital signs, become overt late in pregnancy because your visual assessments are usually wrong. And always remember that if the woman is non-anesthetized, systolic blood pressure less than 100 and pulse more than 100 beats per minute, very simple formula. That means she has lost 15 to 25% of blood volume. Urine output less than 30 ml per hour. Other signs and symptoms of hemodynamic altered level of consciousness, shortness of breath, cold, clammy skin, and pallor are also very important parameters which guide us that the blood loss is there. And another important issue is the shock index. Now, if the woman has a shock index which is 0.9, in obstetrics, it is taken as a trigger for blood or blood component therapy. So this always has to be remembered, and these formulas have to be placed. So I told you the formula of 100 to 100. So if the patient's blood pressure is 100 and the pulse rate is 100, then her shock index is already 1. So you have to remember that she requires help. And then there are other scales which we have used already, that if the patient is having palpitations, tachycardia, weakness, sweating, bradycardia, all this restlessness, confusion, pallor, oliguria means 25 to 35% of her blood has lost. So that much blood loss is something which the woman will not very swiftly be able to compensate, and she requires help. Now let's look at this patient who is a Gravida 3 para 1A1 prom at 39 weeks, induced with misoprostol 100 mcg. You can see a wrong dose. After 6 hours, 2 centimeter minimally effaced, mild contractions, second miso was given, 50 mcg was administered. Now, usually it is always better that once the patient's cervix starts dilating, don't give misoprostol. You can start doing oxytocin augmentation, but here miso was given. After 1 hour of the second miso, she had severe pain and bearing down. Pervaginally, she had become fully dilated. Immediately, you can see within no time she became fully dilated, was shifted to the labor room, delivered, and collapsed. Now, since it was in a tertiary care center, we asked for the blue code. She was resuscitated, intubated, immediately shifted to the operation theater. And a quick per-speculum examination showed that she had a tear at a 6 o'clock position. So we decided to do her laparotomy, and you can see here that there is a bucket handle tear on one side, and there is a hematoma posterior to the uterus. So we quickly went ahead and did a hysterectomy and an internal iliac ligation, and that helped us in saving this woman's life. Now, sometimes women will not be so lucky, and similar case, we had one woman who went into cardiac arrest and died. And this was because of precipitate labor. She landed in amniotic fluid embolism. The moment the amniotic fluid embolism happens, the woman can go into DIC and shock. And there are various other reasons as well. There can be myocardial infarction, cardiomyopathy, high spinal opioid respiratory depression, drug overdose, toxicity. So many things are there. And therefore, no precipitate labor, indiscriminate use of misoprostol has been found to be a huge culprit in trying to do these things. So always whenever we have a primary PPH, it's always good to have wonderful algorithms in place displayed so that sometimes when you get confused, you have cues to do what you can. Antenatal risk assessment is extremely important. And then when the patient comes in labor, do risk stratification, find out what are the risk factors. Intrapartum and postpartum assessments are extremely important in these women. And then record observations on the standard maternal observation charts. They are extremely vital because they will then help you in segregating women, whether they are normal, whether they are having a moderate risk or a high risk. And many times complacency has been found to be a reason. Once the baby is born, the placenta has come out, we all are happy, but there are so many women who may go into postpartum hemorrhage a little later after this, and therefore we have to be vigilant. And always categorizing these vitals into zones helps so that we can take the correct actions based on this. I'll not go into details of this, but this is something which has been adapted from the 2021 guideline of postpartum hemorrhage, and you can refer to it. It's on the Google. It's a wonderful chart according to me. Now let's look at Amina. 3 years back, a low-risk mother, 38 weeks, prompt for 12 hours, had an irritable uterus, cervix admits, tip of finger, no effacement, sublingual myso was given 50 micrograms. After 4 hours, complained of acute pain and uneasiness, cervix 1.5, 30% effaced. Again, second myso given. After 45 minutes, became fully dilated and taken to delivery table. And she also had a massive hemorrhage, obstetric hysterectomy, and pelvic pack was kept, ICU, inotrops, DIC management, dialysis, uremia, went into trally and eventually succumbed. So don't downregard these things, and these things are actually happening around us, so be very careful. So the presence of squamous cells in the pulmonary arterial blood obtained from Swan-Ganz catheter, once considered pathognomic for AFE, is neither sensitive nor specific. And the monoclonal antibody TKH2 may eventually prove more useful in the rapid diagnosis, but till that time, friends, we have to depend on our clinical judgments and try to avoid all these conditions which will cause amniotic fluid embolism. So there can be acute hypotension or cardiac arrest, hypoxia, coagulopathy. Onset is usually during dilatation and evacuation, because what happens is the cervix becomes extremely thinned out suddenly and the placental sinuses open up in the myometrium, and from there can be air embolism, and therefore one has to understand these things. So coming back to what we are doing in our PPHs, we are looking at thrombin, tissue, tone, trauma, and any other reasons that we find. And we have to remember that all the factors are also parallelly having a constant music of coagulopathy running, and therefore one has to be vigilant, especially women with Asian ethnicity, anemic, who have been induced, whose BMI is more than 35, have had prolonged labor, and age, younger age and older age, both act as risk factors apart from the rest of the risk factors which we are very well aware of. Now, you can see here that this is Arunima, who had come on to us on the 10th day of delivery. She was referred to us, and she had a history of fetal full-term vaginal delivery, and after 16 hours in her own primary hospital had syncope and was resuscitated. And then the doctor was not a gynecologist. He used to run a practice there. And then after about 10 days, a gynecologist came and saw the patient, and she said, you please shift her out because she has uterine inversion. So this was on the 10th day. I purposely recorded the laparoscopic picture for study for my students. There was no indication of doing a laparoscopy. But then I was considering maybe if I can give her intramyometrial prostaglandin, that would probably help. And you can see here that this is what has been happening. I had a surgeon colleague down there putting his fist, and under general anesthesia, with proper relaxation, we decided to reposition the uterus after 10 days. And you can see here that the entire uterus requires a lot of strength because the cervical ring is extremely tight and the uterus is sort of entrapped along with the adnexa there. And I'm actually trying to assist from above, but it's really not helping. That feast only has to work, only probably it is guiding him. that, okay, the progress is going on. And you can see the uterus has been completely now repositioned. And then we try to even inject an intramyometrial prostaglandin. Actually, if you look at the uterine folds, it already showed that the uterus was well retracted. So that wasn't something which was indicated. But sometimes you become extremely vigilant, and that is what happens. So we have to remember that severe traction on the adnexa and the pelvic peritoneum can cause uterine inversion, and therefore one has to be extremely patient when we are delivering placenta and not pull it out, because then we can have such kind of things happening. Quick decision making and action is many times very, very important. So you can see here that this patient is bleeding. So you may have to take her on the breast sutures, or you may have to consider doing an internal ligation, or you have to do something which can be used at least when and that can help us in trying care. So many times you may have to consider doing the surgical intervention if the patient is bleeding, and that can help us in trying to save lives. So preparedness is again important. As I told you, there's a primary, let's say 38 weeks, poor bishops in oblique lie, hemoglobin 9 gram deciliter, risk factor 2.5 lakhs platelets, blood pressure 140/100, risk factor, preeclampsia, risk factor because of coagulopathy, and she was in the schedule for elective C-section. So apart from the rest of the things, you have to have a strategy for PPH management with everything ready there. You must speak to your anesthetist, what uterotonics are we going? If she goes into PPH, what are we going to do next? Sutures, bloods, volumes, access, UPTs, everything has to be remembered, and the entire team should be in place. So these are the very well-known risk factors of postpartum hemorrhage that we are aware of. But one has to also remember that even in low-risk populations having vaginal births, most women developing PPH have no identifiable risk factors. What does that tell us? That we have to be always on guard. Any time this PPH can strike, but when we have a striking risk factor at the background, be more vigilant so that you will be able to avoid. Now, I always like to speak about anemia as a cause because this is our publication from Assam in BMJ Global Health 2016, which showed that in women with severe anemia, there is 9-fold higher risk of developing PPH, while women with moderate risk as well, 9, less than 10 hemoglobin, she has a 17-fold higher risk of developing postpartum hemorrhage. And therefore, always the rule has to be at the time of birth, the woman should be facing labor at 12 gram per deciliter. So as I mentioned, always that risk factors may not always help you, but they can if they are there. Now, management of the fourth stage of labor is extremely important, where you have to look at the fundal height, position, firmness, assess the perineum and the episiotomy, assess the woman, comfort her, and assess lochia. And then, if your first response of PPH bundle is something that has to be taken into account if the woman starts bleeding, and there has to be a proper protocol inside your institution, designed by you, depending on what is your goal chain, what is your cold chain, what is your comfort level, which oxytocin when you're going to use, because the team at the head end, the anesthetists, your nursing staff, all have to be well versed, whether you're going to use carbetocin, whether you're going to be using oxytocin, whether you're going to use methergine, prostaglandin, in which case. So all this checklisting before delivery is extremely important. And at this now in time, carbetocin is yet not been promoted for treatment of PPH. It is only yet recommended for prevention. So all these things we should be well versed and they have to be revised. Now, if your first response bundle fails, then you may have to take recourse to the refractory PPH bundle. As you saw, compressive measures, intrauterine balloon tamponade, non-pneumatic anti-shock garments, and a continuing dose of uterotonics. And you must consider doing an aortic. Always, this is something which helps. At the time of C-section, you can, through the open wound itself, give aortic compression. If the patient has a vaginal delivery, still you can give, and that can help in saving many lives. And that is known. How much is the pressure? Till you are not able to palpate the femoral pulse. So that much pressure you must apply, and that will help in reducing the pelvic pressure. Bimanual massage not only helps in elevating the uterine vessels and reducing the pelvic pressure, it compresses the placental bed. It also stimulates the myometrium, and it also helps us in diagnosing whether there is any trauma around the uterus And anecdotally in history, there has been a woman whose life has been saved by that obstetrician by continuously applying bimanual pressure for 3 hours. And therefore, don't regard this particular measure. It can help save lives. Everybody should be absolutely well versed and they should be part of our drills of putting intrauterine balloon tamponade. Currently, there is a study which is coming from South Africa where they found that it is not useful. And the rider is it is not useful because it was not properly placed. So learning to put this balloon properly is extremely important for achieving hemostasis. So at the point of everything, you have to remember that triggers, bundles, protocols, and checklists are extremely important. And every maternal care provider needs to know this. And therefore, always have your algorithms in place. There has to be stepwise maternal resuscitation and approach to postpartum hemorrhage. And when an obstetrician is around there, well vigilant, well trained, usually women won't die or get morbid. And this is my last slide, which tells you about the golden hour for postpartum hemorrhage. And this was a result from a prospective cohort study published in 2022, which concluded that shock index and heart rate measured after birth showed high specificity with low sensitivity to identify PPH in clinical practice. The rule of ones should receive special attention, that is shock index more than 1, heart rate more than 100 beats per minute, and estimated blood loss of more than 1 liter. Very, very important, and act on it immediately. At the end, I would like to conclude with a prayer that no woman bleeds to death or disease when delivering the future human legacy, and none of my colleagues experience this heart-wrenching malady ever in their lifetimes. Intelligent anticipation, skill supervision, prompt detection, and effective institution of therapy can prevent disastrous consequences. And always remember, the time is running out. Thank you. At the end, I would like to appeal to everybody to kindly vote for Dr. Monica Singh.
Thank you, madam. Thank you so much, ma'am.
Girija ma'am, me too. I also need your blessings and support.
Yes, certainly, of course.
It was a beautiful, beautiful talk, ma'am.
Yes.
And chairpersons, would you like to make a comment? Dr. Rupali, Dr. Dipti?
Aditi ma'am has also joined, ma'am. Aditi ma'am.
Aditi is here. Madam, Dr. Aditi is here. She is your chairperson, and she joined a little late. Aditi, would you like to speak or something?
Ma'am, good evening to everyone. Ma'am, actually, I joined a little earlier, but I was caught up in a section. Thank you, ma'am. Listening to you was like, as revealing, I always feel scared when listening to any talk on PPH. And as you very rightly said, you pray that none of your colleagues ever face it. But as you also said, preparedness is the utmost thing. We have to be prepared with everything. And I think, ma'am, your talk covered everything comprehensively, expertly. Everything was covered very well. It was an excellent talk as always. And I'm very junior to you to comment anything else. So, ma'am, thank you, ma'am, for an excellent talk.
No, my dear, your comments are very, very important because it's actually the junior cadre who is facing these situations more often. We are usually sitting in our offices and guiding from there. But of course, in practice, I do a private practice as well when I'm by my patients. And so even I face, and I'm sure that many of you must be facing these problems. So therefore, we have to be always on guard and never ever think nobody is junior and senior for PPH. We have to be all together there.
Ma'am, what I feel is asking for help on time is more important because
So therefore, as a society, I like to give you a message here that be very, very, create a wonderful team within your society. You have to have good colleagues and good friends. They have to be there. You need help. You can't do these things alone. Because finally, if everything goes wrong, and most of the times the staff around us is not always well trained, your anesthetist should always be your dear friend, dearest friend. And there have to be 2 obstetricians and gynecologists who will always be there for you when you need them, because it will come only when you go for them. So therefore, rather than wasting time in comparing, fighting, and generally, rebuking others, it's always important to create a good symbiotic relationship with each other so that we are able to face such challenges better.
Yes, ma'am, rightly said. And in our society, we follow this. And I have Sunita ma'am to thank me. I have to thank Sunita ma'am. I had a case of DIC. She ended up in postpartum hemorrhage, and Sunita ma'am's place is around 30 kilometers from my place. And the minute I called her up in the middle of the night that I'm bringing her this patient who is bleeding and due to DIC, she openly said yes. And team of 3 doctors was waiting at the doorstep to receive the patient. The patient was received well. Her bleeding was controlled by suction cannula. And then later on, the patient, she had an acute renal shutdown. She was referred to Indore. The patient survived. They came back to thank me. And they came back and said, we will handle the next delivery. So, this is how the
Ma'am,
team
we
was
have very
managed.
good team, ma'am. Very good. I mean, it is a true example of
Congratulations.
having a good team.
Congratulations,
I had-
Aditi and Sunita. But
Thank
most
you.
importantly, Aditi, you have to remember this legacy which Sunita has given to you.
Yes, ma'am. In our society, I remember, but I cannot profusely, we were up the whole night. And not even ma'am, sir was also sitting and Dolly ma'am was there. It was teamwork, and I could just, take off the load from my shoulder and hand it over to them and, have a breather for some time. So
last year
what
we
was
had a DIC patient, ma'am, and there were 9 gynecologists from Ratlam sitting in my hospital for whole night treating that patient. The patient did not survive, but it was the teamwork that really made, a good spirit for everybody.
Absolutely. Great. Very
That
nice.
is so commendable. That is so commendable. Really.
Thank you. And best of luck to Monica ma'am and Dipti.
Yeah,
Thank
Monica, Dipti,
All
best
the
of
best.
luck.
Thank you, ma'am.
Thank
And
you
thank
so
you for
much.
being
Thank
here.
you, ma'am.
And
दीप्ति
thank
तो दीप्ति शायद जीत ही गई है इलेक्शन ऐसे तो लगा
ऐसा कुछ नहीं है मैम
elections are elections, ma'am. Till the results, you're always, on a
Best
pendulum.
of luck. Best of luck.
Many surprises to come.
I
And
think
ma'am, I think in your talk, especially, little things about misoprostol, about augmentation, I hope the postgraduates, and even if they were not listening once, Monica ma'am shares the recording link, like she said, she has been compiling very nicely. These are the things which most of us don't pay attention to, and they make a huge difference in anticipation and prevention.
Absolutely. And actually, one more thing which I did not add is now we should start adding factor 7A also in our checklist of our refrigerators, because the company has promised that they will do replenishment if we are keeping those drugs in case they expire or are not used. So as a society, we can create one repository, maybe a storage place where we can keep that drug, use it, and if it's not used, they'll take it back.
Ma'am, that's, I think, a very good idea and tip that at society level, we can probably have a collective one PPH emergency thing.
Yeah.
Excellent. Thank you so much, ma'am. Always good learning tips.
Thank you.
Thank you, ma'am. Thank you very much.
Girija ma'am. And at the end of Symbiosis, Best of Symbiosis episode 2, I would like to again thank Foxy. I would like to thank our two tremendous speakers. One was myself. So I would like to thank Dr. Girija Wagh. I would like to thank Charmila ma'am, our most brilliant VPs that Foxy has seen.
Yes.
And Girija ma'am is so busy. Sometimes she picks up the phone while driving, while in OT, in OPD, but she always says yes to me.
Yes.
So ma'am, I'm so obliged. My coordinators are at, all nerves. Girija ma'am is not picking up the phone.
Yeah.
Not
I
replying.
told her, I asked her which to be seen. Where is it? What am I talking?
I said, see, don't worry, madam will be there. If she has said yes, she will always be there. So that is the reliability that, madam, you have, the aura of reliability around you. And we are blessed, madam. Thank you so much, dear chairpersons, for your love, affection, and kind wishes.
Thank you. And
Coordinators, Neetu and Purva. And thank you, Dr. Vishal, for always being there.
Thank you, ma'am. Thank you.
Platform. And we end up Symbiosis on 23rd.
All the best, ma'am.
Symbiosis part
Thank
two.
you, Monica
Dr.
ma'am.
Dipti.
Best of luck once again.
Best of luck, both of you.
Thank
Thank you, ma'am. Thank you.
Thank
All
you
the
so
best to both of you.
Thank
And
you.
thank you for having me here.
And these two beautiful lectures on LSCS and PPH will be available to all of us to see on YouTube very soon. Thank you and have a very good night. Bye-bye. Bye.
thank you. Bye.
Bye,
Good
ma'am.
night, ma'am. Bye.
Happy call,